Thank you very much, Your Excellency, the Deputy President, COG, the governors, Your Excellency, COGs, all protocols observed. Good morning. So we'll give an update on implementation of Taifa Care. And we will begin with the benefits package. As you know, this was our benefit package for the primary health care. What we had informed Kenyans is outpatient, inpatient, maternity, and optical services for minimal tariffs. But what was excluded in the first year was end-of-life services and screening and management of precancerous lesions. Regarding the social health insurance funds, then we had the benefits that are there, which is inpatient, maternity, renal, hemato-oncology, mental, surgical, imaging, among others. Incorporated and bold is overseas treatment, which again has been highlighted, but it was actually incorporated in year one. But those that were included in the shift included outpatient and oral health dental services. Regarding emergency, chronic, and critical illness, what we had said is emergency evacuation, stabilization, and resuscitation. And what was excluded in year one was critical care, chronic illness, assistive devices, and palliative care. And so even as been highlighted by His Excellency Honorable Abdullahi, critical care has been a challenge, and we have good news with regards to that, equally regarding the primary health care and the overseas treatment. So regarding the establishment, we have established the benefits package and tariffs advisory panel, and they will be reviewing the benefits package every 2 years. That is to identify the concerns and critical components that need to be addressed urgently and for them to be implemented as we had seen earlier, such as the critical illness. And the UON, through the Center of Epidemiological Modeling and Analysis, is going to host the panel and joint secretariat. So the vetting of the nominee CVs is ongoing, and a review of the MOU is underway. It will be signed by 24th February and gazetted by 28th February. So we want to assure you, governors, we are not sleeping in terms of benefit package. We have advisory team on board, and if there are any concerns and grievances, then they'll be exhaustively addressed by this. So these are wonderful news for us. We have revision of the benefit and tariffs package. There's additional funding through the supplementary budget to facilitate, number one, an increase in funding for ICU. Previously, we were at 4,480. We are happy to report that now ICU will benefit from 28,000 Kenya shillings per day. Equally, that's good news. So again, for oncology services, we are happy. Previously, we were at 150,000, and following concerns from the public, we have been able to increase. Sorry, we were at 400, but we have increased to 550,000, an additional 150 for the oncology cases. So again, that is a good point for us. And equally, in the later slides, you'll see the issue of procurement, bulk procurement, to ensure that the prices of some of these medications are worked on. And after review, the revised benefits will go through the legal process for gazettement. Again, another concern that has come up from Kenyans is the overseas treatment, and the SHE Act provides for overseas purchasing of healthcare services not available locally. However, this requires accreditation, empanelment, and contracting of the providers and facilities overseas. And so we continue undertaking overseas treatment. Work is ongoing. We need the Ministry of Health, KMPDC, to review the patients who are going outside, and after giving they can go outside, then they can be seen. But let us remember that currently we are having 500,000 shillings for this, all inclusive. So maybe I can highlight, at times some of these things may not be addressed. It's important that they go through review by KMPDC, they go through review by Ministry of Health before they are released, because we've had challenges of patients going to facilities that have not undergone the right accreditation, or asking for money to be sent into their bank accounts, etc. So this again is a need by need basis, and needs a review by our team. Again, means testing. Previously, as you know, our previous means testing, people would cheat the system, and this has had great impact in terms of our average. You'll see later on, our average currently is at 560, I believe, and yet we need 880 for this as an average means testing for the system to be sustainable. And so we went back to look at the means testing, and we have a new algorithm which is under development. And it will rely more on data triangulation from other existing databases in government agencies for improvement of the accuracy of means testing. So the database will include KNBS, KRA, Immigration Department, Hustlers Funds, KPLC, among others. So the data has been requested. We are collecting all the data and reviewing it, and we believe that we should be able to roll out the new means testing very soon and plug it into the insurance premium financing, because ultimately for the system, for Taifa Care to be sustainable, we need to have the resources at hand. So we want you to encourage people, even as they register, they need to contribute. That way, when we have resources, sustainability is again successful. Okay. So our key asks. First of all is the funds for payment of old NHIF debts. As you know, there are a bit of lamentations from healthcare providers, and so we are working to finish up on that debt. Equally, the civil servant scheme that is included to facilitate access of healthcare services for our civil servants. Again, additional funding for improvement of benefit packages because of the concerns that have been raised by the Kenyan people, and identification and financing of indigent population by counties. IPF implementation, again, to support informal sector is really critical. That way we can have contributions up and running and have a successful implementation. Again, we need your support, dear governors, in the rapid registration initiative for SHA registration, as well as a premium payment in the counties. That way we'll have enough resources to make it sustainable. Regarding human resource for health, for the CHPs, we have more than 107,000 CHPs in Kenya, and the national government has provided 100,000 CHP kits. And government has allocated resources for the payment of 100,000 CHPs in the country, 2,500 from national government, 2,500 from county government, totaling to 5,000 per CHP per month. And the payments of CHPs across all counties have been effected up to the month of December 2024. 8,571 staff have been transitioned under the UHC program, and process on the implementation of commitments made to doctors, nurses, and clinical officers is ongoing. Equally, public officers medical scheme for funds for public officers is ongoing. So these are the commitments for return to work formula for the doctors, and you can see the issues raised, including basic arrears, internship, harmonization of union members' employment by national government, postgraduate arrears, among others. And we are happy to report that 11 of these issues have been addressed. The one remaining is the internship component and conclusion of the CBA. As well as employment of additional doctors to support the implementation of UHC. So I think we need to highlight that during our meeting in November, December, we talked about 206, but for the new cohort, we are talking about 70,000. And so negotiations will start to ensure that, again, this is implemented. So the ERLC in Eldoret rendered judgment on consolidated petitions on 17th October, upholding the legality of SRC circular. However, the court observed that SRC rates were at variance with the 2017 CBA, and it directed that we negotiate with the KMPDU within 90 days. And to forestall the strike, as I said, we met in December 2024, and interns again were posted. The CBA rates were effected, and now there's a current cohort that will be joining of 4,332 in all cadres, and there's need to resolve the salary or stipend rates of the interns once and for all. So as I said, we'll be having meetings, and as you can see, these are the 4,332 graduates broken down in the various cadres: medical interns, dental, pharmacists, etc. And below you can see the budget requirements for up to 2025, for June 2025 from financial year 2024-25. So you see that using the SRC rate, we will be able to save a lot of resources and support to the doctors, and we look to, and other healthcare workers. So we look to start our engagement with regards to that. Regarding the pending CBA and negotiations of new CBA, cognizant to the respective independent corporate existence of the various entities under national government, KMPDU shall within 90 days from the date of this agreement conclude on the CBAs for each, and the employers will on a priority basis seek the advice of SRC. So concluded was the CBA for nursing union for clinical officers is ongoing, pending with the Treasury, and the KMPD is to audit the status of implementation of 2017 CBA and present the report for deliberations. For the doctors, additional doctors to support UHC implementation, the government shall establish mandatory staffing norms for various levels, and in furtherance of this national endeavor, the government shall employ 2,000. And thereafter establish a policy for annual recruitment and placement of doctors, pharmacists, and dentists. So a technical working group and steering committee developed a HRH policy, and the Ministry of Health Staffing Norms and Standards reviewed the policy that was developed, and the employment of doctors will be done over a period of 2 years, beginning financial year 2025 to 2026. Funding will be provided for either in the 2025-2026 budget. A budgetary provision of 6 billion is required, and the hiring will depend on the needs and based on the results. The hiring will be at various levels, from ministry, county, and at the national hospitals, the semi-autonomous government agencies. Regarding health commodities, KEMSA's mandate is procurement, warehousing, and distribution of HPTs, and it partners with counties and strategic partners. They have, they're using LMIS to collect, analyze, and provide regular HPT reports, and they support counties in health supply chain strengthening. The key role in UHC, accessible and affordable quality health products, and extending economies of scale to the counties. KEMSA, however, faces challenges in endeavor to ensure sustainable stock availabilities. The challenges, you can see stock availability stands at 53%, and order fill rate after back orders on average is 65%. Constraints affecting stock availability: COVID-19, health program, HPTs strain the cash flow, and the long-standing debt of 6.1 billion. Counties contributing 3.5, MOH 1.4, and development partners 807 million. There is also delayed payment to suppliers, with 1.5 billion being over 90 days. And you can see the total pending at 2.4 HPT and procurement for 2024-2025, and the projected cash flow needs being 8.5 billion. So key asks to counties: to settle the outstanding bills by counties to restore financial stability. That way we can have improvement in capacity at your facilities and also KEMSA. COG to concur on debt remittance of direct remittance of debt from TNT to KEMSA in concurrence with COB, and the COGs again to concur on net off by SHA to KEMSA for SHIF and PHC HPT debt. We'd love to hear more about implementation of that. Then concurrence that KEMSA remains the first choice for all public health facilities. That will be able to capacitate it and ensure that supplies are always there to reach the last mile. Regarding a comprehensive integrated health system, the objective was a national comprehensive health information management system to enhance efficiency, effectiveness, transparency, and accountability. And MOH contracted the consortium led by Safaricom. So for the digital superhighway, you can see those are the components: the health information exchange or the registries, and the health management information system. And those are the systems, the e-claims, SHA, ERP, registration, and National Logistics LMIS. So what have we been able to do so far? For registration, we are happy to report that we have self-registration, assisted registration, employer portal. We had our means testing, but we are reviewing to have the new means testing that will incorporate the various data agencies that we had talked about. For the claims insurance management system, we have the provider portal ready, and the claim payer engine and post office system. They are reviewing and working on the SHA ERP. We've been able to distribute 5,665 devices, and 3,000 are in the warehouse, and 62,000 will be delivered by March. Regarding health information exchange, we are happy to report that we have the clients registry, the health worker registry, facility management system, the health terminology, and national shared health records. Now they are able to be rolled out efficiently. HMIS development was complete. Baseline survey ongoing, and HMIS rollout to follow in suit. Training, 11,600 have been trained, and 71 physical trainings have taken place. Supportive supervision and mentorship is ongoing. Our key asks, I think we had a best practice from Mombasa, and we want to encourage counties to implement this with more than 87.5 of their facilities being digitized. And I believe His Excellency the Governor will give a best practice and how he's been able to secure resources and ensure sustainability. So we are encouraging the signing of intergovernmental participating agreements, conducting baseline assessment per county on what is available, and then uploading all the healthcare workers to the Health Pro. So another concern that has been raised is US government funding, and what is the ministry doing about that? As we know, the global fight against HIV, TB, malaria is mainly supported by PEPFAR, PMI, Global Fund, and UNAIDS, and all deriving quite an amount from USG. Kenya has been overly dependent on the donor-driven vertical health programs, and yet there was a stop work order which has disrupted USG funding worth 30.9 billion. HPT being 24.9, HRH 5.8, HMIS and health system strengthening also being affected. Additional multilateral funding for vaccines, nutrition, family planning of about 17.2 billion are also at risk. And then the public health security may result to service disruption because of lack of commodity security, HRH, and data systems being affected. So what is the status? Currently, we have 1.4 Kenyans living with HIV on ART, and we are at risk of having 58,495 new infections by 2030 if donor funding is reduced. For TB, we are likely to have 23,500 TB annual mortalities, among them being 20,000 people living with HIV. And for malaria, we're likely to have 12,000 deaths per year, with projected increase because of climate change. And for family planning, 6.2 million who rely on family planning annually are likely to be affected, and yet the gap of 40% has not been reached. Regarding vaccine coverage, currently is at 77%, and the program currently under transition from donor to government funding. So that coverage of 77% is likely to be hampered. So as we said, for commodities, 24.9 is by US government, 79.8 to Kenya, and 79.8 health commodity need. That is 24.9 out of the 79.8 commodity need. And we are engaging diplomatic interventions. On Wednesday, we'll be meeting the US acting ambassador. And we are also developing an impact assessment, of which we will be sharing with the various development matters and diplomatic for interventions. We also need to allocate 24.9 billion for commodities previously funded by USG, and disburse 2 billion allocated, and allocate additional 2.5 for vaccines to avert funding freeze by Gavi. For HRH, we have 41,547 PEPFAR-funded staff affected. And after reviewing, the technical team reviewing this, we saw that 11,559 frontline health workers would be core in terms of transition and implementation, and their cost is 5.84 billion. And there is need for us to approve comprehensive HRH restructuring and highlighting with public health systems. So 41,000, but 11,000 core, 41,000 having been able to support us in implementing the 98, 98, 94 targets. And again, we look to capacitate the team that will continue with the interventions. For data, USAID funds 139 million for critical health-based databases, including Kenya EMR, among others. And we are happy that we have a digital platform, so really it's on time, and we are really ensuring that we are transitioning to the digital and integrating those critical data so that we don't lose important patient data through the cracks. Other critical programs are the blood transfusion program, where 2.8 billion World Bank support is ending in March 2025, and we are securing other funding. This is because one of the high causes of maternal mortality is hemorrhage, postpartum hemorrhage, and so we need to address blood transfusion concerns. Immunization and vaccines, 11.6 billion is required. Gavi and USG support, again, is at risk, and the recommendation will need disbursement of 2 billion immediately and allocate 2.5 billion for Gavi compliance. Family planning require 2.7 B. USG was 598, GOK 508 with the 1.7 form funding gap. And the recommendation is to allocate 598 for continuity and consider 1.74 B in 2025-2026. Equally for nutrition, 4.96 billion required, 2.88 from USG is at risk, and will replace USG funding with domestic allocation. So in summary, you can see from the various pillars or departments, the total is actually coming to 30.922 billion that we require for seamless transition. So our asks, retaining for the counties to retain all healthcare workers for integration of the vertical program into the mainstay human HSS health system structure, and then restructure HRH to the core human resource and integrate the vertical component to Taifa Care, and counties to set aside funds to aid transition from the donor-funded programs. We also need to capacitate our human resource for health even as they transition, so that we don't reverse the gains that we have accrued over the 40 years. So thank you so much. Over to you.
Makofi mazuri jameni kwa waziri wa afya nchini.